So sometimes it could be less difficult to understand to you, but I will show you. How many cases you have? 5. Anthony? 3. And Hector? Yes, me. You have a presentation for me? No. Okay. Okay, Fabián?
In English, of course. No, well, in English, in English. Well, I have 5 cases. The first one is a complication of mine. I'm going to be really open mind and tell you the truth of the way I obtained this complication, and nowadays I don't have any solution for this. That's why maybe you can help me. It's a patient with melasma, and no, this is not the first one. It's the first. It's not so complication of mine. It's complication about this problem. If you have a patient that have a cosmetic tattoo, please be careful about that. This patient have a mastectomy for another colleague and asked me to get improved because the black tint spread around the areola, and it's difficult to measure the shape of the areola by this. And she put she requests for a white tattoo, white tone of the ink in the west of the scars to try to don't see well. But the problem, when she asked me to retard that with a picosecond laser, is that, as you know, the ferric oxide changed to ferrous oxide. I don't know if you understand well. In Spanish is pasa de óxido férrico a óxido ferroso. It changed the color between black to red, as you can see here around the areola. And the problem is that the tone white was made by titanium, and titanium always changed to gray, and it's impossible to have a solution for that. You use 1064, you use 532. I have 2 other wavelengths, 660s and 595, and I don't have successful at all. This is the patient after, I think 15 sessions. She is agree with the color around the areola, but we are still in progress with the leukoderma caused by the picosecond laser in the west of the scar. Well, this is the problem. I asked for a solution.
I've not a magic wand in my pocket. Who want to respond? Who have an ID? The both. Please repeat again.
Yes. If you say that the problem is the hypopigmentation,
yeah,
we only need to have two specific solutions, like Dr. Leal explained. First, do you use CO2? Yes.
I did it.
5% with 100 microns, but you can use bimatoprost or latanoprost.
Okay.
In a LAD, laser-assisted disease. Laser-assisted drug delivery. We
okay.
have many times before, and you have good solution.
I try with both solutions. With your dull explanation, I try it. I use a CO2. I have a CO2. I use in my device. I can choose between high, medium, and low. If I want to have a lot of coagulation, that I want to do it to obtain a hyperpigmentation lesion, I use coagulation. I use low. I try it with that. I tried with high to make holes as a delivery device. Use it the same as you use for get more light and more thicker the eyelids. The name of the drug is Bimatoprost, exactly. Huh?
You can use from ophthalmology. In all the pharmacies, they sell them.
I know. I use it. I try to say that I use it, but I don't have success. I think because I have a scar there.
Yes.
That's why the scar don't act like a healthy skin.
It works when you have no fibrotic tissue, but when you have a fibrotic tissue induced by laser with too much scar, the melanocyte is completely destroyed, and it's very difficult to wake up the melanocyte inside. So I do use, and I had LEDs with blue-violet to stimulate the melanocyte exercise, but it doesn't work. Sometimes we use a Viticel, it's a melanocyte graft, but it's the same product. We do trials 10 years ago. It doesn't work when you have fibrotic tissue. It works on vitiligo, it's perfect. But for fibrotic tissue, when you have too deep with the scar, it doesn't work. It's very, very tricky. For my part, I try to stimulate with radiofrequency, with CO2 laser, with non-abrasive fractional laser, with fabratics, with radiofrequency, with microneedle. I do those things. I put cystianamide, bilamoprost, tacrolimus. It doesn't work. I say to my patient, do a tattoo. Cosmetic tattoo.
Well, I try to don't give advice. Well, I use a trick because I don't say all the truth, because I try with CO2, I try with the bimatoprost, and I don't have successful. I think because it's a scar and don't react as a normal skin. It's difficult to me to set my patient that we tattoo it again because the problem was the tattoo. And I'm still in progress.
Erbium laser would be also a good option.
No have coagulation.
I'm sorry, Excimer laser.
Okay.
Excimer laser.
Okay.
Excimer for to stimulate hyperpigmentation.
Okay.
Sometimes it works. It's slow. It's a slow process. It needs to be done at least once a week with high doses, causing erythema. But what you do, you're right. This is a scar, so we're not going to promote actually pigment inside the lesion, but you can stimulate the melanocytes in the periphery of the lesion, extend their arms, and start injecting some pigment in the lesion.
Now, I'm going to show another problem, another patient that they use the stimulate by the heat light, a LED light, and don't have successful. But Anthony.
No, yeah, I think eczema we use sometimes for vitiligo, but without the follicular reserve, without that adnexal structure or the hair follicle where the melanocytes would reside, it's hard to repigment these because we don't have that reserve because of the scar. So, I mean, sometimes people may do like little punch grafts and catching some of the follicle, but then you're transplanting hair to a place where you don't want hair. But it's interesting because I think you need that reserve to wake up the melanocytes.
Okay, well.
The whole idea was that in this kind of scars, we don't have melanocytes. But Carney, 4 or 5 years ago, performed histology, and he found that there were melanocytes. But the problem seems to be a disconnection between the keratinocytes and the melanocytes. When we have a scar, they arrive at different times, and for some reason, there is a disconnection. So normally, UV stimulate the keratinocytes stimulate the melanocyte, but we need to create a creation. So it's not we only need to work in the epidermis. Yes, in the don't go deep, only in the epidermis.
Okay, you don't look for stimulate the melanocyte.
You only need to reconnect them. There is one excellent publication in dermatology surgery about the treatment of hypopigmentations, yes, and we have been having the same situation for a long time, yes. So I suggest you only need to do small ablative channels in the epidermis, yes, and if you need, remember to use the bimatoprost, but it's very important. 2 minutes, and then repeat 2 or 3 times a day for the 7 days.
Okay.
After the treatment.
Okay.
Are you okay?
Next. Okay. this is my case. This is my complication. A patient with melasma, and I made a lot of energy with the Pico Plus. I mentioned the name of the trademark with the Pico Second laser. In this case, I apply, if I remember well, 2 or 2.5 joules, and the patient in the first month or the first 3 weeks was successful. All are happy, but after the month, after past month, a month go by, a leukoderma and confetti appear. And well, I do a lot of treatment, but first, this is the problem. I hear you.
The assembly, if you want, have an idea. Patricia.
If she was using hydroquinone or some despigmentation.
Usually, all my patients after the treatment, when I can obtain a reduction of the melanin, I indicate inhibitor of tyrosina or inhibitor of plasmina. Or in some cases, hydroquinone. In some cases, tranexamic acid. In this case, nothing.
Oh yeah. Okay. Yeah,
It's not a reaction to hydroquinone.
okay.
I hear you say that you use a lot of treatment. Which kind of treatment you use with hair?
In the next.
I'm sorry.
In the next. Continue. Well, I use a lot of technologies. Highlight is with the A, no with the E. Is a LED platform. Is a low therapy, low power therapy. More than 10 sessions, and I was not successful. I use CO2 over any kind of leukoderma. I was successful. IPL for the west of melasma. It gave me the possibility to try to avoid great difference between leukoderma and the west. In some case, during the first period, I used tranexamic acid oral and topic to reduce again the difference between leukoderma and the rest of the hyperpigmentation. And this is the wood lamp test to show you that it's a clear leukoderma, and the melasma is in the deep because you don't see a great quantity of the pigmenton on the surface of the skin. When you use the wood lamp, if melasma is on the dermis, you see a light color, but when it's in epidermis, you see a great brown color. That's why I think it's really deep in the side of the skin, and this is she's still in progress.
Yes. When you make the difference between the previous, it could be worse because it's not scar.
Yeah.
So you have the reserve of melanocyte. So I believe that if you continue CO2 or maybe erbium-YAG, I prefer to use in this kind of condition more erbium-YAG because less downtime and less redness because patient is unhappy. So you have to manage the patient because you do that, you induce that. So if you explain that after CO2, you have a link time, take more time than erbium. Probably I use that to stimulate, and I cover all on and manage the hyperpigmentation on the hypopigmentation. But probably it will work. And I had LEDs, blue-violet LEDs to stimulate because we know that you stimulate the melanocyte very frequently with low risk, very low risk.
Okay, your recommendation is still with the highlights.
The same. You don't change anything, but you have to continue progressively. I give tranexamic acid really because you reduce the hyperpigmentation of the melasma, so the patient don't see the difference. Yes.
Okay. This is the way I act until now, but I stop with the highlight because I don't see great result, but maybe it's a good advice, continue with that. Okay, Anthony?
Yeah, I mean, there's two problems. You have the leukoderma, but you also have the exacerbating melasma, which it looks like melasma, but you can use dermoscopy to maybe look at the pigment and see if there's a vascular component as well, because sometimes a lot in melasma we're seeing vascularity as well, which you can target with a vascular laser over IPL, which may be stimulating more of the melasma.
Well, the proof is that for sure is in this case because she get more improved with the IPL in the surrounded than that I do it with the Q-switch.
Yeah.
I realized that, well, maybe you have a vascular component. But the patient requests me a solution for the leukoderma.
The leukoderma.
She at this moment, she forgot about the melasma, and she said me, give me a solution for the leukoderma, and I'm still doing that.
I think I would try in this case. Of course, no hydroquinone at all. And I would like to try, like every 6 months or so, if available, a thulium laser, just to cause some scaling, and I think it's something very, very shallow,
Okay.
and very safe. So you can treat at the same time both things. You could help a little bit the hypo or acro, achromic
Acromic lesion. Okay.
lesions, and you could get rid of a big amount of hyperpigmented. So because sometimes the contrast between the two coincidental lesions is what makes it looks very bad. So although the patient is not complaining about the hyperpigmentation, it is important to treat it because the contrast is what makes the white spots look very, very bad.
Okay. Okay.
Yeah.
Good cases.
I would say something maybe very obvious. I don't know if at the beginning did you try with anti-inflammatory like, for example, topical corticoids or immunomoduladores like tacrolimus.
No, I don't do that.
Have done once, no magic effect, but it was not bad. I think with the time, because you can leave it for a year.
Yeah.
And
take
this
a
is,
year.
yeah, I think these immunomoduladores like tacrolimus, they work. And for the other hand, then you try to light a little bit the melasma. I think both together could be a good try.
Thank you for the advice. Well, continue. The problem, labial angioma, male, 33 years old. He had a angioma from birth, of course, but he had a surgical procedure when he was 12 years old, was very traumatic for him, and he refused a surgical solution. He came to me to any other kind of solution.
I have an answer, but maybe.
Vascular laser, Nd:YAG, or looks deeper. There's a deeper component.
Vascular Nd:YAG, or maybe cryosurgery,
Sorry?
cryotherapy.
Cryotherapy.
It could work. Okay, it could work.
For the mucosa, maybe, yes.
But you have a beautiful edema after that, but you can manage. And maybe a radiofrequency, but we mean Hellman, with fulguration.
Like a surgical.
Yes, but it's surgical, but you have specific setting on the Hellman device, and you reduce you focus the energy on the radiofrequency, and it works like a bubble.
Okay,
it closes.
About the cryo.
You fulgurate with a
about the cryotherapy, you
device.
don't have problem with the scar or about a great lesion of the mucosa.
Yes, but with the Nd:YAG, the problematic is the setting, because if too high, you have a scar, you have a crust, you have to manage. So the difficulty is too high, you have a result, but you have a scar, you induce healing times. If too low, it doesn't work.
Okay.
Sometimes with the laser, like what Hugues is saying, if your fluence is too high, it'll burn the mucosa. But what you could do is put a glass slide, like a dioscopy, and you press it down, and it sort of blanches the vascular component on the surface, so you can target deeper.
You shut through the glass.
Yeah.
Well, good advice.
Because you're compressing the top portion of it.
I never think about
You're
that.
targeting the deep.
You just have to, if you do that, if you use a vascular neuritum jag, just have to be very careful in that area with the teeth, because it's easy with that kind of laser to what? Oh, it's easy to actually kill the teeth, to kill the vascular component, and then they fall off.
Good advice. Well,
Yeah.
I have a diodo laser, I have a CO2, and I have an IPL. I decide to combine IPL and CO2. Look that. This is me during the treatment with the CO2, and the way I lesion the mucosa and the angioma inside the mucosa. And here is the result. For me, it's good enough.
Probably less, but you do on local anesthesia. That's right.
Yeah.
Truncular, or you inject a lidocaine inside.
Injectable. I start without anesthesia. The first bad words of the patient, I said, "Oh, I need to put anesthesia," and I put anesthesia. Okay, continue.
Yes.
Well, problem. Patient with surgical indication, as you can see here, he has a lot of wrinkles, sagging skin, fat pad, and dermochalcis of the upper eyelids. 54 years old, Fipatrick 2 is good for us. But she doesn't like a surgical solution. She requests me a solution without a surgical solution. I am plastic surgery. I love to make the surgery to the patient, and my fee is better if I perform a surgery. But the patient is an old patient of mine, and he requests me a solution without surgery.
In one session or in few sessions?
Yeah.
One session or few sessions?
I don't know.
Maybe the erbium with radio frequency microneedling, Morpheus 8.
You add both treatment.
Yeah.
Okay.
And volume reposition with hyaluronic acid or radius.
And a fat is surgical solution, without surgical solution.
If I see this patient, I would choose CO2. I know it's you make a lot of inflammation, but it's great for the deep, for the contraction. I think for that problem, she needs fillers anyway. But if she doesn't want, I think CO2 will be a great decision.
With the filler, what do you
No, I think
you guys to be successful for the wrinkle and the dermochalcis?
No, I think you can, maybe she needs more structure. I think maybe, try to help her with fillers, maybe in the deep compartment. But she needs tightening. She needs, I think CO2 will be a good laser for her. Cuidando los ojos con buenos protectores eyes por dentro. Yo le haría un CO2 arriba y abajo del párpado. Una o dos sesiones, depende cuánto ella quiera, as much as she wants.
One question to you. Do you see the lower eyelid? Do you think the risk with CO2 is to induce apoptosis for this case?
I think you have to be careful anyway, because she has, but I think if you are careful, she's not going to be great with CO2, but I think she will improve a lot. Because CO2 is making this tightening, you can see in the minute. Of course, not very, I try to do it no so high energy because it's for the zone. And with careful, I think she's not going to have ectropion. No.
Hector, Anthony.
I always check the lid.
Yeah.
You check what? Really?
To check the lid, like do the snap test.
Yeah, Snapchat.
Because if she has anything,
It's not positive. She have a wear retraction. We don't have any problem with that.
Yeah, but I do agree, like CO2 would tighten those up nicely. But she's going to be red for, that's my biggest problem, is that the prolonged erythema is like 6 months to 8 months,
And another option for the lower eyelid would be inside the laser The
diodo laser inside the skin?
smart lipo.
Okay, okay. I
Uh,
know this treatment.
Well, optic fiber.
Yeah, exactly. Okay. Well, it's a free 2. That's why give me the possibility to be really aggressive with the CO2. I decide the CO2. 120 millijoules. 120. And several passes. Several. She was with this size of the face during no less than 10 days. She called me every day, every night. Was a great headache for me and for my wife.
She has your mobile or not? Your phone mobile, you give to her your mobile?
Mobile?
The phone number.
Oh yeah, of course,
Yes.
yes. You need to do that. If you be so aggressive, you need to do that.
Okay.
And my wife, and my wife need to believe me that it was a problem and not other cause the patient called me.
Yes.
Well, the awareness during a complete month, awarenesses, but it's only one shot, only one session. The patient is really happy with me. She is still my patient. Okay, I think the last one, another vascular lesion, another angioma. The problem the patient is not only the aesthetic problem. Sorry, a minute? 1 minute? Okay, I finished? By way? Okay, the problem of the patient is she is still bleeding, especially about the columella, because the patient she mentioned that he take anabolic treatment, steroids, and he said that he's a medical doctor, and he said that especially see a difference between the complete start bleeding and the start increase the volume of the angioma. Well, I hear you.
I work in a big hospital, very big. I think maybe this is not for us. This is not for laser. should send him to the vascular to do an echography to see where are the big vessels, and they can do it with intravascular. They work with that. I think it's a little risky for us to try to help him, even the blaring, because it's very deep.
Yes, but maybe you can make a sclerotherapy deep, but you think you will have some result for the superficial angioma? I don't think so.
Yeah, I think, well, it's interesting after the anabolic steroids that it grew. Yeah. That's interesting and unique. So I think you could approach it with a vascular laser to get the superficial vascular component, but also a resurfacing laser to debulk some of that, like a non-ablative fractional or erbium to resurface the cutaneous lip. But if it's also bleeding every day, you can use topical timolol or like the topical beta blockers to try to shrink that.
Perfect.
Yeah.
I need to go fast. Yeah. I try to the section that is still bleeding is the columella. I try to destroy with the diodo and with the CO2, both in the same session, and start bleeding a lot. It was a problem for me. I need to put the stitches. That's why I said it's a surgical solution for the columella. I made the surgical solution of the columella, but on the rest, I apply IPL, CO2. It's really thicker, the angioma. That's why nothing happened with the IPL, with the CO2 on the surface. And I start to doing that. Diodo laser inside the angioma. If I go really over the surface, not inside the muscle, I can destroy the orbital artery. That's why it's still safe, even if you see this is really aggressive, and it's still in progress. The moment I say I doing that last week or 2 weeks ago, and the way I think I be successful is because in the same moment and the same time I I feel tough, thicker on the skin, under the skin, like fevers. That's why I for sure I obtain a destruction of some part of the angioma. But well, I am still handle with that. Okay, it's good enough for me.
Good work. Thanks a lot.
Okay.
Mm.